Yeah, okay. Welcome, Professor.
Thank you very much. Thank you for this second invitation. I'm very proud to be giving the very few knowledges I know, but I'm very happy to share it with you, and hopefully I can have some hint and new ideas from you as well.
Sure. I think we should be able to start in a few minutes, but I think...
Dr. Ahmed, we are live now.
Okay.
Okay. So you may start.
Okay. Good evening, everybody. I would like to welcome you all for our second webinar session with Professor Nicole Portinero, Professor of Pediatric Orthopedic and Neuro-Orthopedic. He is the head of the department in Humanets Research Hospital in Milano University. This is his second lecture with us. Today, he's going to talk to us about very interesting and challenging subject in pediatric orthopedic field, which is cerebral palsy. As everybody knows, that cerebral palsy is a challenging problem, and it's a multidisciplinary disease where more than one specialty is involved in the management of such cases, including physiotherapy, occupational therapy, neurosurgery, urology. Too many different specialties involved in management of such poor kids. We hope that we will learn a lot tonight from our professor, and I would like to welcome him and thank him for his great presence with us. And I'm leaving now the microphone for him, and we will have enough time, inshallah, at the end of the lecture for discussions and questions. Welcome, Professor.
Thank you very much. Thank you very much for the invitation. As I said, I'm very proud to give this lecture, which is going to be divided in an introduction part, which is a general concept about CP. And on the second part, we're going to go through early and late surgery, which divide the world, because myself, and my team, we've been describing with some American friends early surgery, just especially because I'm lazy, and early surgery is minimally invasive, while if you do big reconstruction, as in late surgery, then is major surgery, big rehabilitation, and is very, very challenging for the surgeon, especially is very challenging for the patient. As we know, is a group of permanent disorder. People don't heal, which is sometimes very frustrating, because if you do a hip replacement, the patient is happy. But what's happening, in my experience, if you do a hip replacement, the patient is happy and then forgets about you. While those children are very happy, they never heal completely, but they're very grateful for all their life for what you've been doing for them. So we got an abnormal tone. This is something that you probably, you definitely know, and I'm just going through it quickly. Abnormal coordination and abnormal posture is the most common disability in childhood. In fact, we got the American Academy for Cerebral Palsy and Developmental Medicine, which got nearly 4,000 people, 4,000 parties. And still, it's not like spina bifida, because the spina bifida, now we found that if you take some medication like folic acid, the incidence of the disease is lower now. While in cerebral palsy, because neonatal intensive care units are able to maintain in life people or babies which are very low birth weight, and 460, 400, 600 grams, well, 50% of those children may develop something like cerebral palsy disease. So we have this contradiction where better ability to cure and treat may end up having more disabled child around. So the incidence of cerebral palsy hasn't changed in the last 20 years, in fact. We know that there are some prenatal causes, and I'm not going to read through this because it's too long. And we know there are perinatal causes and postnatal causes. And this is, can tell you that, the pathogenesis of the disease can be, in fact, very large. We go from malformation, we go to syndromes, we go to asphyxia, we go to infection, blood incompatibility, and hemorrhages, sepsis, injuries, and so its pathogenesis is very various and compound, but still 30% of children with CP, they don't have a confirmed and definitive diagnosis. We got spastic cerebral palsy, which is the most common, which is, of course, divided in diplegia, hemiplegia, and tetraplegia. We got dyskinetic cerebral palsy and ataxic cerebral palsy, which are less frequent in terms of incidence. Of course, in children, they can able to walk. The limitation in gait are directly related to neurological damage. Of course, the most damage you may have in the brain, the most involved is the musculoskeletal system or the pyramidal system, who drives the control to the musculoskeletal. There are, after the geographical classification, which is, diplegia, hemiplegia, etc., we got the functional evaluation and classification. We've got the GMFCS, the gross motor function classification, and we got the functional mobility scale, which is very useful if we have to talk from Milano to Cairo or from Milano to Dubai. We can talk about a classification so we can understand immediately which patient we are dealing with. GMFCS is 80 items that are evaluated per patient, while the functional motor scale tells you if you can walk for more than 5 meters, for more than 50 meters, for more than 500 meters, with or without crutches or device. There are different other classification like functional assessment questionnaire or the pediatric outcome data collection, which they haven't been so sophisticated in terms of dividing and sharing ideas. Now, what I really think that's very important in cerebral palsy. I mean, as an orthopedic surgeon, the first thing we examine the symmetry, we examine the muscle development of difference between the two limbs, and we are very keen and obsessed about range of motion. Well, I do think that in cerebral palsy, the last thing you need to detect is, of course, the lack in range of motion, because, of course, being spastic muscles and later on in age with deformity, I mean, the range of motion is the least of the problem, because as an orthopedic surgeon, as we are orthopedic surgeon, we can straighten everything, and we believe we quite like God, we can do everything. But in fact, the most important thing in cerebral palsy is examining the patient without the range of motion, but examining the patient all around it, as in the tone, as in resistance to effort or during the ambulation, in fatigue, we see so many people, they stand in tiptoe, they stand in equinus. And after 3 minutes, you can see them sitting down, losing power on plantar flexions, and they go to crouches. So they go to crouch, and crouch is one of the most difficult problems to treat. So we need to understand that power associated with fatigue and resistance, they're very important before you do any surgery. Think if you got an equinus, you lengthen the tendon, but if there's no power down there, you run the risk of having a child not able to walk anymore. So it's better to leave him some equinus than to do a iatrogenic crouch gait. And then the last bit that I kind of assess when I examine a patient is the range of motion. We got different scale for the tone. The Ashworth scale, which is an old scale modified in '87, and it tells you the spasticity during slow passing mobilization. A scale that I quite like to use is the Tardieu scale, which is in fact tells you how much the muscle catch during fast movement, and so you can tell how spastic is that muscle and how spasticity is together with the agonist and antagonist muscles together. And then we have the muscle skeletal alignment, which is very important, and we'll see, because at the beginning we go through the persistent fetal alignment, which is present in all normal child, which unfortunately, due to spasticity, and poor muscle control, it persists in child with cerebral palsy. So we end up having a malalignment, which is going to be introduced later on as the liver arm dysfunction on spastic hip dislocation, femoral anteversion, femoral valgus neck, tibial anteversion, lower limb discrepancy, foot malalignment. And this is something that makes the child mechanically incorrect, if I may use this term. So if you are mechanically incorrect and the liver arm are not right, you will never be able to use the remaining of the power that you have with the disease. We got scoliosis, and we got all these tests we checking, the light Duncan test, the femoral anteversion test, just to go through, just to remind myself as well what we have to do when we examine a child, the popliteal angle, which I actually don't believe it as much. And I believe that more than the popliteal angle, I believe in the fixed flexion deformity of the knee, because if you examine a child properly, more frequently the knee flexors or medial and lateral hamstring are never short. They just due to a position of the knee compared to the position of the pelvis. So it's something I do when I test the child, but I'm not very happy to rely on this for any major surgery or any lengthening. And this is for the rotation. And this, just to introduce my obsession, which is the foot. As you all know, so I'm just repeating knowledges that we orthopedic surgeons know. If you don't have power, or if you have deformity at the feet, you will never be able to produce the plantar flexion knee extension moment, and you will never be able to produce the three rockers during the heel strike, the flat foot plan, and the push off, which makes the knee straight and make you to be able to propel the body in the space. Silver scale test is a fantastic, very easy test, very clever, and tells you the difference between the gastrocs and the soleus. So one thing we have to remember is the soleus is the big engine that keeps the tibia steady when you need to do the push off and push as well the knee backwards. If you lengthen the soleus, you destroy the biomechanic of walk. So you have to do the test to detect if the soleus, which is very rarely compromised in terms of length, and you have to detect when the gastrocs, they're too short and they need lengthening separately from the soleus. We do imaging, and we all know that we're taking X-ray, pelvis, lower extremity, and spine, and especially we do the CT study for profiles of the femoral and tibial torsion, which are very important before we do any derotation osteotomy of the femur or the tibia. And then we do the gait analysis. In this talk, which I just feel it's a very friendly talk because I felt very, very welcome from you all. We're just gonna hint about gait analysis, but we're not gonna go through gait analysis. I'm just gonna give you some example on how I use gait analysis and why it's so important. And this is the typical evolution of a hip which progressively become dysplastic, become dislocated, and needs to be relocated. As Dr. Hamra El-Batu, sorry, my pronunciation of your name, had said that sometimes the cases are neglected, and this has been a neglected case. He should have been operated in 96, put the hip back in, maybe reconstruct the pelvis, and that would have been easy and with good outcome. Now here, in the last X-ray, we see the T-drops is gone, the acetabular socket is completely shallow, and the femoral head start to be deformed. Now, this is how we evaluate the torsional profiles, middle of the neck of the femur, posterior part of the condyle, transmalleolar line, and we can detect the rotation, the bone rotation. We published this nice paper with a big friend of mine, Professor Staninsky, now retired, and Deborah Staninsky. And we did that. We saw that the intra-observer and inter-observer variability is very low if you're an expert surgeon. If you're not an expert, not surgeon, actually, examiner. But if you are not expert, you need an important learning curve. So just few think about gait analysis that you all know. Cinematic is a description of body movement in space, and kinetic is the moments and power of different districts. What is great about gait analysis that is able to quantify the error or the degree of movement and quantify the power produced. So you have an immediate idea from any graph that you have a look at that what is the mistake, what is the error, and what's maybe the chances you have to correct it. Is a very non-invasive. Now we can have associated the electromyographic. This is an old image. Now we got wireless electromyographic. We do 16 channels. So we can do both sides together, the trunk, the pelvis, and it's very important to detect muscle spasticity and the error in the torsional profiles as well. And this is just to give you an example for people who are connected, who are not expert. If I give you this graph, and I think you probably be able to see that, this patient has got an anterior, if you see the arrow, an anterior pelvic tilt, the hip are flexed, the knee are completely flexed, but the foot are in dorsiflexion. So this is a typical graph or a child in crouch gait. And if we go here in the lower graph, we can see that the child is not producing power, especially on the left, which is red, it is not producing power. So the problem is to correct the ankle power to have knee extension and hip retroversion and hip extension as well, because otherwise the walking would not be possible. So the treatment and the aim we have is to improve patient motor skills and sometime to improve symptomatology. And symptomatology you have, especially in children, with kind of a late presentation to the orthopedic surgery, while the motor skills, which I call the remaining of the motor skills, are in younger patients that you may treat with benefit with very minimally invasive surgery. So the treatment should be tailored and according to type of CP, age of the patient, power, as I said before, resistance, and malalignment, and especially with liver arm dysfunction or bone, or what I call the human frame or the body frame pathology or malalignment. So we got, as we said, physiotherapy, we got all the different orthoses, we got baclofen pump, which in some child are very indicated, but it should not be used as a routine method because the classification, the selection of patients that you may have for baclofen pump is very rigid. Some American colleague, they did a study about baclofen pump and surgery and dorsal rhizotomy and surgery. And if you select the patient nicely and accurately, probably dorsal rhizotomy is more specific and gives better result for surgery, changing the outcome index. You can use Botox and both Dysport and Botox for very young children. I don't think Botox is something that you should repeat regularly every 2 months because you're going to end up having a muscle full of scars, which is not less spastic, it's just completely destroyed. So my idea is that Botox or botulinum toxin should be used, slightly carefully in terms of repeating the doses. Dorsal rhizotomy, very difficult to select the patient. They shouldn't have any dystonia and should be younger than 12-year-old because otherwise it doesn't have any good results. Deep brain stimulation is another thing I just wanted to quote, only because we're still very late in studying this technique to decrease the spasticity. Now, the most important thing to understand when you see a patient is that you need to know the prerequisite of normal gait. So you have to have stability and balance in upright position with 2 feet standing on the ground. You have to have a correct swing phase because otherwise you're going to hit the feet on the ground and you're not going to be able to do the step correctly. You have to be correct in stand phase, so to have a normal foot being lying flat on the floor, and you have to have a correct step length. And this is all due and necessary to have conservation of energy. So in normal walking, you have a correct anatomical lever arm, muscle tone is normal, correct walking phases, and the deambulation is correct. While if you have an abnormal anatomical lever arm, an abnormal tone, and abnormal walking phases, you have the pathological walking. This is just to summarize again. So those child don't move from fetal alignment to adult alignment. They got a persistent fetal alignment of the femur in terms of anteversion and valgus, of knee, which frequently become deformed in terms of flexion deformity, high riding patella, which decreases the lever arm of the extension mechanism, tibial malrotation due very frequently to foot deformity, which is again my obsession, and it's called the flexible lever arm, both if it's equinus varus or if it's a mast equinus and is pronated valgus. Now, surgery, it's something that we like to do, but in this case is as my, now I call him friend Amr El Batu, Tuti, sorry. And it's something very difficult when you have to decide, because there's so many million different bits and pieces you have to put together for each single patient. Now, when I call it preventive early surgery, is preventive in term that the prevention is to modify the evolution of the skeletal system in terms of having a more adult and proper liver arm system than if you leave it without any operation that doesn't improve, doesn't change, and remains completely useless for what is the child needs. So we do percutaneous fixation of the femoral head, we do tendon transfer, we do 8 plates, we do a little screw in the calcaneum, we do a transfer of the tibialis anteriors, we do transfer of the semitendinous, and we do a percutaneous patellar distal advancement. While the late surgery, as we all know, include the rotation varising osteotomy, periacetabular osteotomy, femoral head resection, or other operation if it's completely too late to reconstruct the hip. And we do the osteotomy, the rotation osteotomy, open wedge, closed wedge. So we all do the kind of the different surgery that is massive to put up for the patient. Big surgery, they stay one night in ITU, in pediatric intensive care unit, because we want to be safe. They lose a lot of blood, and especially the difference between the two is that with early surgery, they can go back to physiotherapy very soon, while with late surgery, it takes a long time because we need the bone to heal, and then they lose power in the muscle. Don't forget, we believe that cerebral spastic palsy is a contradiction in term, because we're talking about palsy and then we're talking about spasticity. So the two things go together because we got an hypertone but a decreased power. So I think surgery should be planned on patient age, deformity, cost-benefit analysis, and all the clinical features that I kind of discussed before. So for example, if you got a knee fixed flexion deformity due to a decreased power in plantar flexion, you may end up having a child very young, 7-year-old, with a fixed flexion deformity of less than 20 degrees. So what I do, I transfer the semitendon on the adductor tubercle. So I make the semitendon becoming from biarticular to monoarticular. I decrease the power of flexing the knee, but it remains the power to extending the hip. So I don't have the risk of having the trunk bending forward even more. But if the fixed flexion deformity is higher than 20, but less than 30, then I put the anterior 8 plates, especially if the child is young. So we got a lot of growth remaining. And of course, if the fixed flexion deformity is 40 degrees and the child is 12, you need to do an extension osteotomy, which is a big enterprise. So we're going to go through different steps in the different stations. So we do what is called the hemiepiphysiodesis of the proximal growth plate of the femoral head, transfer on the semitendinous, 8 plates anterior on the knee condyles. We do what we call the dynamic patellar stop, which is a percutaneous anchorage of the patella, and transfer it distally. And we're very careful, as I said before, to do not the Achilles tendon lengthening, but we do the Wolffius or the white, which are normally sparing the soleus. And then we do all the transfer on the foot, because I think realigning the foot at any age is the most important thing to get the patient up and go. This was for what's concerned the proximal femoral epiphysiodesis. That was published in 2009, where we tried to do an early surgery and multiple approaches in different motor station. And this is the results. This was a dysplastic dislocated hip, which is not now the indication, because now we're restricting the indication with an acetabular index less than 30 degrees and a Reimer index no more than 50 degrees. But at the beginning, we tried to save those hips. And if you can see the remodeling of the acetabulum in 5 years, we put those screw that stop the proximal growth plate to grow. And of course, the greater trochanter growth is spared. So the idea is, if you see the neck of those two femurs, the idea is that the growth of the greater trochanter have a varising effect. So also the varising effect is associated with a varus effect and a centralized effect in the acetabular socket, with remodeling of the socket as well. And we have been publishing on Journal of Pediatric Orthopedic a huge series, the largest in the world, with 10 years follow-up, and we had very little complication, no AVN, and 3 or 4 cases over 200 that needed a further proximal femoral derotation osteotomy. And this is how I do the transfer of the semitendinous to the tubercle of the adductors. It's a very simple operation. The patient needs to be in a brace, which is the 0 degrees or minus 10 degrees to keep the knee extended, but he can have physio the next day, because you see that the tendon is armed with a Korsakoff suture, and then is fixed on the adductor tubercle on your right. And this is how we do the extension using anterior 8 plates, as probably I have mentioned the last talk I gave to you. And they work very well. Of course, as my friend asked, when you do the surgery, well, you do the surgery as early as you can, or better, as early as is needed. Because if you got a fixed flexion deformity because you don't have any power distally at the foot, you run the risk of having a flexion deformity of the knee, even if you're 4 or 5. So if you put a 4 or 5, a 6-year-old, the power of growth of the posterior part of the condyle is still very high, and you have the fantastic result of having a straight knee in 6 months without having touched any muscle. And touching the muscle and tendon in cerebral palsy is always very dangerous. And as you can see here, the knee got, I'm very sorry for the images, and the knee got straight in very quickly, and the result was very happy. Of course, when you do this surgery, it's not enough to do one surgery at the hip and then wait and see. When you do this surgery, I started from the hip, but we do all together. So you do the hip, you do the knees, and especially you do the foot. So normally I start from the foot, I realign the foot, then I realign the tibia if necessary, but this is late surgery, because if you realign the foot when the child is young, you don't have secondary deformation of internal or external rotation of the tibia. If you realign the proximal femur, then sometime you derotate the internal rotation of the femur, so you don't need to do a big osteotomy and derotate the femur when they're older. And this is the high riding patella, which is a big problem. And some of the child during the swing phase, they don't have the extension mechanism power to land with the knee straight when you have the heel strike on the gait analysis. And Of course, to treat the high patella, high riding patella, we got a lot of options. Till 4 or 5 years ago, when we described the percutaneous anchorage, we had the anterior advancement of the tibial tubercle. We got the extension osteotomy. We got soft tissue surgery, which is very dangerous, or combined surgical technique. So studying the biomechanics of the patella and the fulcrum or rotation of the condyle, we described this surgery, which is very easy. It's you just have to release the rectus femoris. You anchor the patella on top of it proximally. You put a big key wire and you cross it. You take it out percutaneously. You make a hole in the tibia and you make a knot underneath the tibialis anteriors, so you don't have any risk of having any bruising or any problem with the brace when you use it. And the good of this surgery is that is minimally invasive, passive motion of the knee from 1 day post-op, immediate loading, and immediate physiotherapy. So they don't lose power. They increase the extension mechanism, lever arm, and it works very well. Hope this going to start. This is how, when you mobilize the patella, you lock the patella with a big 5-0 of Ticron. Then you're gonna reach the patella and the Ticron, you're gonna cross it underneath the skin, and then you put a spinal knot on through the bone hole that you made before, and you push the patella down. Please have a look at how at the end of the operation, how the patella is straight away lower down. Look at it now. If you see the inferior margin of the patella before the surgery, look at now is probably 2 or 3 centimeters lower down. So this is easy surgery for people who are lazy like me, and it works very well. And this is the results. You can see the hole in the bone, and the patella is never at the right place, but is in a better position, and the child doesn't have an extension leg. And the same thing is for the foot. If you got a plantar valgus foot, we put a screw. You can put in you can put in the talus through the sinus tarsi, or you can put in the calcaneum, and it works very well. This is a minus plantar valgus foot, and you see after you put the screw, straight away the child can walk on it, and the restoration of the medial arch is immediate. Now, to restore the power and the mechanic of the foot, especially when it's an equine virus, we do, the problem is an imbalance between the peroneal tendon and muscles and the tibialis anterior. There used to be a very happy fashion about doing the splat or split, whatever. So splitting half of the tibialis anterior through and put it to the cuboid. But this doesn't work as well as we think we're doing. And I've learned this from Luciano Diaz from Chicago, which he actually detached the whole tendon, and he put the tendon on the second cuneiform to have a complete neutral dorsiflexion of the foot, because sometimes you got just a soft tissue deformity. Of course, if you wait too long, you're going to have a midfoot and a rear foot, like a calcaneal deformity, and then you have to do a foot reconstruction bony-wise, because transferring the tendon is not enough. And this is how we treated a child. And the child, this is pre-op. You see the deformity. He's an hemiplegic 12-year-old child. So sorry for the noise.
Tira sulla maglia, che si vedono bene le mutande, molto bene. Vai, così, vai.
You see the deformity, the upper and cavus foot. And this is after surgery. You know, the child has grown up. He's now 14. Sorry. And see how he's walking. Oh, I'm very sorry. It's been turned around. But you see, he's completely plantar flex. The foot is hitting the floor properly. Sorry, they all twisted around. This is when the child was, I don't know what's happened, but doesn't matter. If you look at the child foot, now he's walking normally. And, you know, the child was very happy because he had a normal gait. He was not embarrassed with his friends, and he was a happy boy. And this is dynamically, you see the foot is coming up straight. It doesn't come in dorsiflexion and supination. And this is when the child was slightly older. He had a fairly normal gait, and you could not tell he's been operated unless you look at the leg diameter, and which is slightly different. Now, this is a nice early preventive surgery. Is a nice little toy that we do, and it's difficult to convince patient and parents to have surgery early, but it's the only thing you may do because it prevents late surgery, allows the child to improve, and in fact, allow the child to acquire a lot of chances to learn modality and scheme of walking more near to normality than otherwise. Late surgery, we all know, and I'm probably late in time as usual. This is a hip reconstruction. We did bilateral femoral and pelvic reconstruction. And at 3 years, the hip looked fine, and the child is walking a bit again. He was a diplegic and is a happy chappy. This is a dislocated, neglected hip. The child was 7-year-old. We have to do a posterior approach to the knee because of the capsule, and because the growth plate here is still open, but it would take too long to extend the knee. So we did bilateral and femoral derotation, pelvic osteotomy, and we did some plates for leg length discrepancy. This is a dislocated hip, deformed femoral head, completely destroyed acetabulum bilaterally. And one of the idea that I shared, and we did it together with Professor Selbert now in New York at the Presbyterian Hospital, is that if you do a femoral head resection, or if you do a shunt or a valgus osteotomy, the femoral head is still impinging on the acetabulum. So the child comes to see you only because got pain. This is a tetraplegic child. And the problem is that if you release the head, you're going to have the stump of the diaphysis who's going to rise up because of spasticity. So what we did the pan release. So we cut all the muscle in the proximal third of the thigh, and we leave all the vascular, only the vascular nerve and vascular bundle attached, and to decrease pressure. And the patient are very happy because the pain goes away in a couple of weeks. They can do rehabilitation straight away, and pain and hematoma are not so huge because I use the diathermy. And it's one of the solution, because there's no one solution. There's one of the solution if you do surgery for late hip. This is another case of a completely dislocated hip, and we did a resection of the femoral head with the problem that I just mentioned. And this is the last bit on hips. The hip should have been operated on the first X-ray, and probably a reconstruction would have been enough to remodel the femoral sphericity and the socket. but the child waited and it was completely destroyed. So we had to do a bipolar femoral hip replacement, hinged because of the spasticity. And this is the distal femur. We all do this. We calculated the degrees of the rotation. This is a simple derotation osteotomy. This is a pathological girl with spastic diplegia and from India, deformed feet, completely deformed knee. We did the calculation preoperatively, and then I used a plate proximally to correct the valgus. And I use in a reverse mode the putty place, where it's normally used for correcting the varus of the knee. I used it for correcting the valgus. And I think the alignment is pretty good on both sides, and she's very happy. Now, flexible lever arm, I'm gonna go fast. Very important, heel strike. You have to land with your heel. You need the plantar knee flexion, knee extension moment to be able to propel the body through the space and to move forward. And you have to have a push off, which is powerful, because otherwise you will not be able to extend the knee. We did a study on segments of the foot, and we've been able to normalize the reciprocal movement of different segments of the foot, and we're going to apply this to cerebral palsy. And so we're studying the moment, the kinetic, so the power before we do any operation. And we did the operation only on bones. And doing the operation on bones, we redid the gait analysis, and the graphic will completely different, because the power that you can see on the last part of the graph, which is virtually zero, so there's no generation of power. If you do surgery on bone, it's completely restored or nearly. We got the different foot deformity, as we said, equinus varus, planovalgus, which they can end up in very difficult cases to treat, like in this tetraplegic child. And those feet, a lot of the physiatrists say they don't need any surgery, but in fact, they do need surgery, because you can't wear any plaster, you can't wear any shoes, and you're not going to be able to dress the child. So the treatment goals, we believe that if you got a walking patient, diplegic, you should never do arthrodesis, but you should correct the foot deformity with osteotomy, and you should do otherwise arthrodesis to have a better rigid stability and better compliance to orthosis in patients who are tetraplegic or bedbound. And so we did this triple osteotomy described by Mubarak and modified by us. Well, according if it's planovalgus or varus, which is called the reverse triple C osteotomy, and we correct the alignment of the lateral and medial pillar, and the best thing, we correct the heel position, so we can have a plantigrade foot. And I'm going to go fast. The results is, this is the pre-op. This is the operation. We did the calcaneal osteotomy. We're using simple key wire, not very expensive. And this is the results after surgery, which is quite interesting. And especially if it's tested with gait analysis, gives you an idea on how much the patient has improved. This is another case. And as you can see, the foot is better than it was before. And the power of pushing, or the push-off phase, has been regated back. Those are other cases. And of course, those foot are completely deformed. The right foot was like the left foot. We did major surgery with big arthrodesis, and at the end the foot was fine. Here again, in tetraplegic, we prefer arthrodesis to stop painful movement and to restore anatomy. This is another case of a reverse triple C on a cave of varus foot. We did a triple osteotomy plus the calcaneum, and this is the results. This is the pre-op. And you can see this is the immediate post-op, pre-op, and post-op. So it's quite rewarding, and it's very nice operation, very simple, and you know, not expensive at all. And this is again triple osteotomy for severe planovalgus foot. At the end of surgery, I did it this last week, just to show some fresh blood, something that orthopedic surgeon loves to see, because if no blood, no operation. What about this? I mean, this is a tetraplegic 40-year-old. The child was in pain and he couldn't wear even socks because of the deformity. So we did a astragalectomy, we did a calcaneal osteotomy, we did mid-foot medial and lateral osteotomy. I have to do a plasty because of the dorsiflexion contraction of the skin. And I think at the end of the operation, I did it last week as well. And I think at the end of the operation, this is a foot which is, it's nearly plantigrade, can wear an orthosis, can wear socks, can wear shoes. Unfortunately, I don't have the late post-op. Cerebral palsy, and as you can see from this is too late. This is late surgery. We can mend it, but we had to do, you know, the first line of carpal bone removal plus an arthrodesis, and the results is fine, but the undertaking for the patient is very big. Thank you very much for your attention. This is after my 3 girls and my wife and cerebral palsy. This is my 5th big love of my life, my little toy. Thank you.
Thank you a lot, Professor Portinaro. This was very informative and actually answered a lot of questions that we had in mind. So we are now open for any questions from the audience. And let me start with a question of mine. What is the role of tenotomy, I mean percutaneous complete tenotomy, in CP? Do you ever proceed to tenotomy, or you use some muscle lengthening or something like this?
I don't like tenotomy, full tenotomy, because if you do a full tenotomy for fixed flexion deformity of the knee in a tetraplegic, which is 25, you run the risk of losing the control of the pelvis. So if I got a fixation deformity of the knee, I do an extension osteotomy, and then I do a muscle tendon junction release. But I prefer to leave the tendon intact. So I transfer the tendon interior, but I very rarely do a full tenotomy.
Okay, thank you.
Dr. Ibrahim, you are mute. Can you unmute yourself, please?
Oh, you can hear me now?
Yeah, thank you.
Yeah, thank you so much for the nice lecture. Really, it was very informative, and it covers a very wide topic, and you could make it in a short period of time. The problem with the cerebral palsy, it has like, I think it is multidisciplinary disease that needs multidisciplinary care. And I wondered whether it is possible that when you are treating those patients, you're getting any pediatric neurologist and pediatricians involved with the management of those patients, and also if there is any other branches get involved, like psychiatry, etc. So, is this the case in your institution? Is it multidisciplinary, or it is just only orthopedic decision to go forward?
No, I entirely agree with you. I think you thank you very much for the question, because this is very, 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 very important. In Italy, the system goes that you know, the patient as the rehabilitation medicine doctor, the physiatrist, who run the show. So the patient goes there, then the rehab doctor send it to the neurologist, send it to the neurosurgeon, send it to the gastroenterologist, send it to the rehabilitation, to the physiotherapist, and then send it to us.
Yes.
What I do in my experience is I got some physios who do the clinical examination. Then I do the clinical examination. Then we sit down, we have a look at the gait analysis, and we compare the two clinical examinations, and then we decide to do. Of course, sometimes the physiatrists, they send the case to us because it's not their branch, so they're not able really to decide when. I mean, I'm fighting with them because I need them to send them early, because early you can decide to postpone, but if they send the patient too late, you cannot postpone, but you have to do big reconstructive surgery.
There is another questions about in our institution for these patients with contractures, we prefer to give them a chance of Botox injection first. And really we use this Botox injections, we use it as a guideline, because if there is improvement in the function of the muscle with the Botox injection, mean that surgery with lengthening or soft tissue release will improve. So I don't know what is your intake on that, of having this Botox injection as a guide for contracture release for those patients.
Well, I think you're right. I was going through the Botox because I think we all know it. I think my idea is I start Botox when they're 2 or 3 years old and see how they're doing. And I think my idea of Botox is that you're buying time. So, you can be able to stretch the muscle, lengthen again the muscle. But my idea is that contractures and spasticity, or better, contraction, are not important for me. Spasticity and biomechanics are more important. So if I have a contraction of the knee flexors, but I have a foot which is not plantiflex, then I try to treat the foot as quick as I can, and as soon as I can. And then I do the rest. So if I got an equinus, you're right. I think I inject the gastrocs, see how it goes. I do a lot of stretching, put in an AFO, and see how it goes. But if the foot is going back to equinus, I'm very careful of what I'm doing. That's why I'm never lengthening the tendon. I'm doing a muscular tendon junction lengthening or sliding, because I'm very worried if I lengthen too much the Achilles, I lose the power and I'll have crouch gait. If I lengthen too much the knee flexors, I'm going to have a flexion, anterior flexion of the pelvis and the hips. So I'm very scared. I'm not brave. I'm not brave.
Professor Bortinaro, we have a question from Dr. Mohammed Mahrous. He's asking about the derotation osteotomy of the distal femur that you have shown a case similar to it. And he's asking about the level of the osteotomy. Do you prefer it to be distal always, or you can do it proximally, as he's feared that the distal osteotomy may increase the valgus factor and predispose to patellar dislocation? So what's your opinion?
Well, thank you very much for the question. I do the proximal femur derotation osteotomy when I have to correct the valgus. So I have to correct one of the lever arm dysfunction. When I got a normal center of the hip proximally, which is not too much antiverted, I'm quite happy to do it distally. I use the 95 degrees plate by Synthes, which very easy to use and because the derotation is 15 degrees, 20 degrees. I never had any patellar dislocation, unless they using the internal rotation of femur and tibia to lock the knee because they don't have power. Then this is a risk. And if they got these gait patterns of internal rotation and locking the knees, I don't know if I'm explaining well. Then I do it proximally. But sometime I did bifocal. So I did a proximal derotation and a distal internal rotation because of the patella. I think he's right.
Thank you for your answer. So my last question, how fast do you go with your racing car?
Well, this is a little toy. It goes 250 kilometers per hour, but it weighs only 700 kilos. It's all plastic, carbonium. So this is a racing car, and I'm having a great fun.
Dr. Albert, does I have a time for one question?
No, I think this is the best question since now about my car, of course. Yes, of course. Please, please.
I have a questions regarding, I see that you are using 8 plate for osteotomy.
Sorry, I'm using.
You are using 8 plate.
Yeah.
For osteotomy.
No, actually, I'm not using. I'm using the 8 plate instead of the osteotomy. So I'm putting the 8 plates when the child is 5 to 7. So the growth is very fast, and the knee straighten in 6-8 months.
So you are using it for physis to have like a growth arrest?
Yes, I'm using exactly. I'm putting them anteriorly, just parallel to the patella. And so I got a growth arrest in the front of the knee, but still got growth on the back of the knee. So the result is that the knee straightened.
And my other questions is about this semi-tendinosis transfer for the femur.
Yeah.
Do you resect it from the proximal tibia, from the medial side of the tibia?
Yeah, exactly.
So you take the tendon from there, then you pull it all over, then you put it in the femoral adductor tubercle. Is that right?
Yeah. Yeah.
And this is
I suture it to around the adductor magnus.
Okay. And the idea of here is to reduce the flexion of contracture of the knee.
Because normally the semitendinosus is the most powerful knee flexor.
Yes.
So if you take it away, but you leave it attached, it's still working as a hip extensor during gait, which is very important.
Yeah. Very, very clever. I like that. I never saw that before, really. But this was really very good technique. I like it.
No, I'm not very clever. I'm just very lucky and lazy.
No, it is good. A good one. Really good trick.
Thank you,
Dr.
Okay, we have another question from our curious doctor, and he is asking about the tibialis anterior transfer. Which patient to choose for split transfer and which patient to choose a complete transfer, and if the power of the muscle is the determining factor for this or not?
Now, when you do the transfer, you got an hyperactive tibialis anteriors, which is not balanced by the peroneal muscles. Now, if you split the muscle, you lose power in dorsiflexion. And you can never be sure about the balance. So you would never have a neutral dorsiflexion. So now for me, the split tibialis anterior transfer doesn't exist anymore. I transfer it entire in the middle of the foot on the second cuneiform. And as you've seen on the video, the foot becomes dorsiflexing, and the child is quite often normally landing on his heel. So he's got a heel flat foot push off, which is very similar to normal.
And my last question, do you ever consider a talectomy for complex foot deformity?
Oh, yes, I love to do talectomy. And the trick in my operation theater is I win a bottle of wine or a bottle of whatever if I can take all the talus intact out from the foot.
Which is a very hard job, I think.
The very deformed foot that you've seen, I did a talectomy because otherwise it's not reducible.
Thank you, Professor. Dr. Ahmed, please, your last comment onto the subject, please.
Actually, I would like to thank Professor for his nice and well informative presentation, and we hope that we will see him soon in the future. Hopefully, as we said in the beginning, next time will be physical meeting rather than this Webinar meetings due to the COVID situation all over the world. Thank you very much again, Doctor, in my name and in SGH group name as well. Thanks for all my panelist colleagues, and thank you for all for your attendance. We reach around more than 100 attendee for this lecture, which is actually a good number. Thank you, everybody, and have a nice night.
Thank you very much for inviting me. Bye-bye to all.
Bye-bye.
Goodbye to all. It was an honor to have you.
Ciao.
Arrivederci.
Arrivederci. Ciao, ciao.
Bye-bye.
Bye-bye.